Good morning, good afternoon, good evening. It depends on where you are, which part of the world that you are in. Welcome to today's presentation at KitCamp and NS1 YouTube channel with me, Cindy. I'm an EN, BSN, and RN. And on this channel, we talk about all aspects of your health. So in today's discussion, we are going to discuss about acute diarrheal disease. So remember to like, share, and subscribe to the channel so that you'll be notified every time I post a lesson or any video. So let's move on to our today's discussion. So we are going to discuss about diarrhea. So before we go into the introduction, let me just walk you through the objectives. So the general objective is that the student should be able to acquire knowledge on diarrhea and be able to nurse a patient with the acute gastroenteritis. So under specific objectives, you should be able to define what diarrhea is. You should be able to state the causes of diarrhea. Then you should be able to explain the pathophysiology of acute gastroenteritis. You should be able to state the signs and symptoms of moderate and severe dehydration. Then you should be able to explain the medical management of acute gastroenteritis, and you should be able to explain or describe the specific nursing care of a child or a patient with acute gastroenteritis. Then you should be able to explain or state the preventive measures and the health education that we can give to a mother or a patient with acute gastroenteritis. So let's move on with our discussion. So as you can see from this picture, acute gastroenteritis affects the gastrointestinal tract or the digestion system. So it's a very much common pediatric condition, but it also occurs in adults. So in adults, it can also come about due to either medical or surgical conditions. So it's very common in hot season. So like the way we are in October, we are in hot season. So at this moment, we have a lot of cases of diarrhea disease. So it comes about due to ingestion of anything which is contaminated, such as food or water, or use of contaminated utensils during feeding. So let's define some terms. Let's define diarrhea. So this is the condition that affects the gastrointestinal tract in which there is frequent passage of watery or loose stools of more than 3 times in 24 hours. So diarrhea is the passage of watery or loose stools of more than 3 times in 24 hours. Then dehydration, this is a loss of fluids and electrolytes from the interstitial and the intracellular space of the body tissues. So this is dehydration. So we should also know that dehydration is also classified as no dehydration, some dehydration, or severe dehydration. So now let's move on to the definition of gastroenteritis. So this is a standard definition where in case it comes in an exam, you should be able to define it this way so that you are able to get the 5 marks that they may require of you. So acute gastroenteritis is a condition that affects the gastrointestinal tract in which there is inflammation of the stomach and the intestines. It is caused by viruses such as rotavirus, bacteria such as Salmonella, and parasites such as hookworm or roundworms. It is characterized by loss of body fluids and electrolytes. So this is through diarrhea or vomiting. So that's how we can define gastroenteritis. Remember that we have mentioned the organ that it affects, that it is the gastrointestinal tract. And then what happens there is that there is the inflammation of the stomach and the intestines. And what causes it? It is viruses such as the rotaviruses, or bacteria such as salmonella, or parasites such as hookworm or roundworm. And then it is characterized by the loss of body fluids and electrolytes through diarrhea or vomiting. So that is the definition. So let's now look at the risk factors of developing diarrhea. So poor weaning practices where the baby is given solid food or too dilute can result in this baby having diarrhea. Then premature introduction of food instead of exclusively breastfeeding for 6 months. So we know that the child should be exclusively a child should exclusively breastfeed for 6 months. Now, there can be circumstances in where a mother is unable to exclusively breastfeed for 6 months, such as maybe a mother is working, or the mother is ill, or the mother is absent. So in such cases, you find that a child is introduced to other feeds before 6 months, and that can cause diarrhea. Thirdly, artificial feeds or milk which the baby can react to. So artificial milk such as maybe Nanny One, or is it S26 or 50 something. Those artificial milk, a baby can react to them. So in a case that a child reacts to any element which is found in that artificial milk, can result into a child having diarrhea. So also use of utensils such as maybe bottle feeding. When these utensils are contaminated with any diarrhea causing agents, maybe salmonella, maybe E. coli, or maybe these viruses that we've talked about, it can result into diarrhea. Then early introduction of bulky feeds such as shima. So even the introduction of food should be gradual. The food should be increasing gradually. Now, when the child is introduced to too bulky foods at a short time, you find that the body, the GIT, is not fully developed to digest bulky foods. So you find that it will cause indigestion. The system will fail to digest the bulky food. As a result, a child will develop diarrhea. Then introduction of too sweet feeds to the child can result into diarrhea. Then any contamination of food or food utensils with diarrhea causing microorganisms, as we discussed earlier. So now let's move on to look at the etiology of diarrhea. What can cause diarrhea? So viruses such as the rotavirus, the novavirus, or the adenoviruses, these can cause gastroenteritis. So that is why children are immunized with rotaviruses, with rota. Yeah, they are immunized against the rotavirus. So this is because we want to prevent the children from developing or from having gastroenteritis caused by the rotavirus. So also bacterial infections. Bacterial infections such as salmonella or shigella or E. coli can cause gastroenteritis. So also parasitic infections such as hookworm or roundworm can also cause diarrhea in children or adults. So those are the things, the microorganisms that may cause diarrhea. So now let's look at the pathophysiology of acute gastroenteritis. So as we can see from this picture, it affects the gastrointestinal tract. So after ingestion of anything which is contaminated, maybe food or water, the microorganisms will move along the GIT, come into the stomach. So the stomach is acidic. So most of the microorganisms may not survive in the stomach. Now, those microorganisms that survive the acidic conditions of the stomach will move on to the intestines, the small intestines and large intestines. Others will start from the stomach. They will start causing infection, inflammation. As they move along the GIT, they will cause now the inflammation in the stomach as well, resulting into gastroenteritis, meaning there's inflammation in the stomach and in the intestines. Now, when that inflammation occurs, it will cause abnormal absorption of water or fluids in the intestines. Let's look at how it occurs. So before we do that, let's look at the intestines. So we know that absorption of water occurs in the intestines. So water moves from the lumen of the intestines into the blood system through absorption. So as we can see from this part, we have this water moving from the intestines, from the lumen of the intestines, into the body cells in order for it to be used. So this is happening in a normal baby, in a normal individual. So water is moving through osmosis from the lumen of the intestines into the body cells in order for the water to be used. So this occurs through absorption. So now, when there is gastroenteritis, when there is inflammation of the intestines, water is not reabsorbed back into the body cells, or the water does not move at a pace that is supposed to move into the body cells. There is increased osmotic movement of water along the GIT. So instead of water being absorbed into the body cells, it will move so fast that the body will fail to absorb this water into the cells. As a result, this water will be lost as diarrhea. So this diarrhea will result in loss of body fluids and body electrolytes. And this is what will cause dehydration. So now, it is also important to know that the movement of water and electrolytes is regulated. Now, when there is an alteration in the movement of water and electrolytes in the body cells, if there is an alteration where there is, in case there is inflammation, as we are talking about, there is inflammation in the GIT, there will be an alteration in how the water and the electrolytes are moving in and out of these cells. So when there is inflammation, this movement is altered. As a result, the electrolytes will be moving out of these cells. Now, as we know, water goes where electrolyte goes. It goes where salt goes. So as the electrolytes are moving out of the cells, water will start now also to move out, following where the electrolytes are going. And this is what will cause dehydration of the interstitial cells because the water and the electrolytes are moving out. So let's continue to look at the pathophysiology. So when the GIT is healthy, water and salts pass through the intestines to the bloodstream by absorption. Then the water and the electrolytes are used by the body. So now when there is diarrhea, when there is gastroenteritis, very little absorption takes place, as we said earlier. Because of the inflammation which is going on through the GIT, the water and the electrolytes are not being absorbed. They are not being absorbed into the bloodstream in order for the body to be used. So this is due to increased intestinal motility, especially of the large intestines. So we know that absorption of water usually takes place in the large intestines. Now, because there is increased intestinal motility, the movement of water is so fast that it cannot be reabsorbed or absorbed back into the system in the bloodstream. As a result, this water will come out as diarrhea. So this is coupled with alteration in the mucosa membrane permeability. So this is what we are saying. The mucosa permeability, the movement of water and electrolytes on the cells is altered. So there is also high osmotic pressure in the large intestinal wall and the rumen. So there is also high osmotic pressure in the large intestinal rumen. So in the rumen here, there is a high osmotic pressure such that the water and the electrolytes are not being absorbed back into the cells. So because of that, this change leads to further loss of fluids and electrolytes as diarrhea. So the end result is dehydration. So the more diarrhea, the more loss of body fluids and electrolytes through diarrhea, the more the dehydration. So this is what we are talking about, that the microorganisms enters into the stomach. So those that will survive the acidic conditions of the stomach, they will cause inflammation and disease in the stomach. So this is what is being shown in this picture. So in summary, we can say that the pathophysiology of gastroenteritis occurs when there is microorganisms in the stomach and in the intestines. So these microorganisms will cause inflammation, and then inflammation will alter the normal movements of electrolytes and water back into the cells in order to be used. So now when there is inflammation, there is an alteration in the movement of these substances. So as a result, a child or a patient will start losing the water and the electrolyte through diarrhea. As a result, dehydration comes in. So now let's move on to look at the signs and symptoms of some dehydration. So remember that dehydration can be classified as no dehydration, some dehydration, and severe dehydration. So in this presentation, we are focusing on some dehydration and severe dehydration. So now let's look at the signs and symptoms of some dehydration. So under some dehydration, we have restless, means restless and irritability. So the child will appear to be less stressed and will be irritable. So the eyes will be sunken under some dehydration. The eyes are going to be sunken. Then the child or the patient will drink eagerly and they will be thirsty. So there is eagerly drinking and they are thirsty. So because they are thirsty, they are eager to drink as much water as possible. Then there is also loss of skin turgor. So the skin, when it's pinched, goes back very slowly, which we call loss of skin turgor. So as we can see from this picture, because there is some dehydration, the child will be thirsty. Now, because they are thirsty, they will be eager to drink water or anything that is given to them. They are just eager. They just want to drink to quench the thirst that they are feeling. Then the mouth will become very dry. Then there is tachycardia, which is a rapid heartbeat. So there's also headache because of the dehydration which is occurring. Then the dry skin coupled with loss of skin turgor will be present. Then there is also decreased urine output. This is because this patient, he is losing or has lost a lot of water and electrolytes which are supposed to come out as urine, which are supposed to undergo through the urine formation process. Now this person does not have enough water, so urine formation is also affected, so there will be reduced urine output. So these are signs and symptoms of some dehydration. So let's move on to look at the signs of severe dehydration. So under severe dehydration, we have lethargic or unconscious. So severe dehydration simply means this child or this patient has lost a lot of body fluids and electrolytes, such that they become lethargic or unconscious. So this child can also be in hypovolemic shock because of the loss of the body fluids and electrolytes. Then the eyes will be very much sunken. Then because they were at that stage when they had some dehydration, they were very eager to drink. Now because they've lost a lot of fluids and electrolytes, they are even now unable to drink. They don't want to drink. They are unable. They don't have the strength to drink eagerly. So in severe dehydration, there is poor drinking or there is totally no drinking, because this child or this patient can even be in shock. So they are unconscious. They also may be unconscious. Then there is loss of skin turgor. When the skin is pinched, it goes back very, very slowly. So these are the signs of severe dehydration. So the child will be lethargic, they may be unconscious, and they may also be in shock, which is hypovolemic shock. Then the eyes are going to be very, very sunken. Then the child will be unable to drink. Remember that in some dehydration, the child was eager to drink. Now in severe dehydration, because they are unconscious, they are in shock, they can't even drink anything. Then there is the severe loss of skin turgor. So this is an emergency. So in case you are working in an outpatient department and the child is brought to the department unconscious, the eyes are sunken, you can see that there is loss of skin turgor. It's an emergency, and then it requires the medical staff or personnel to work as fast as possible in order to save the life of this child. So now they have just come what are the investigations that you're supposed to do? So because it's an emergency, first things first, you have noticed that the child is unconscious, you have seen that there is sunken eyes, you've seen that they are in shock, you need to act fast. So let's look at the medical management. So history taking, of course, if it's an emergency situation, you're just going to assess a child very fast. And then you notice that it is severe dehydration because you're able to see it. Because it's severe dehydration, it requires administration of intravenous fluids. So act fast, set up an IV, cannulate the child. The child has to be cannulated, then administration of fluids has to start. Then as you are doing that, you're also assessing the airway. How is the child breathing? Monitor the oxygen saturation. If they are below, commence them on oxygen. The IV fluid should be running. Make sure that the child is even propped up. If you put them on oxygen, if they are having difficulties in breathing, prop them up. Make the IV fluids should start. Patients should be on oxygen. So those are some of the emergency interventions that you are supposed to do. Now let's move on and look at the medical management. So in case you are in an exam, what in an exam can be in an exam, you can be working. What are you going to do? So what are the investigations? So first things first, history taking. So this a detailed medical history should be taken, and this may review the risk factors such as a child being introduced to solid foods prematurely. So the mother or the caretaker will be able to explain, to tell you that maybe the child has been introduced to some artificial feeds, or they are giving the food which they are not supposed to be given to the child. So history taking should be able to show some risk factors. Then physical examination, which is very important, and it has to be done very fast if it is in cases of severe dehydration. So during physical examination, you should be able to notice on observation that the patient has got sunken eyes. You should be able to notice the loss of skin turgor. When you pinch the skin, it goes back. So those things are going to be noticed in physical examination. So if you're working in the hospital, you can also, or if you're working in Zambia, we also do an RDT. So we want to rule out malaria. We want to test for malaria, because remember that in malaria there's also acute gastroenteritis. So we want to make sure that we rule it out. Then stool for microscopic culture and sensitivity also will be done. This will help us know the causative organism that is causing the diarrhea. Then also urine for MCS can also be done. Urine for examination can also be collected and taken to the laboratory for the investigation. Then a full blood count also can be done, which may review increased white cell count. So those are some of the investigations that can be done. So now let's look at the management of a patient with some dehydration. So with some dehydration, we are going to use the Plan B management. So under Plan B, first you are going to determine the amount of ORS to be given to a child. So as you can see, this child has got some dehydration. You can see that they are eager to drink ORS, and the eyes looks a bit sunken. So we can tell that this is some dehydration. So coming back to determining the amount of ORS which has to be given. So in order to do that, we have to multiply the body weight of the child by 75 mils. So for example, if a child is weighing 10 kg, we have to multiply 10 kg by 75 mils. So we are going to give 7 50 mils, and this amount of ORS should be given in 4 hours. So then the mother will be encouraged to give a teaspoon of ORS every 1 to 2 minutes. And since the child is eager to drink, he will be given more ORS as he wishes. So as you can see from this picture, this child is very much eager to drink ORS. So this child is eagerly drinking. So they can be given as much as they want the ORS. So remember that it should be given in 4 hours. And how much are we giving? We are giving 750 mils. So if the baby is still breastfeeding, the mother will be encouraged to continue to breastfeed the child. And if the baby vomits, we have to wait for 10 minutes. 10 minutes, then give ORS more slowly. We are going to give a teaspoon every 2 to 3 minutes. Remember that first we are giving 1 to 2 minutes. Now we will start giving it a bit slowly, 2 to 3 minutes. Then if the child vomits, we are going to stop ORS a bit and give plain water or breastfeed. So as we are giving this ORS, we are also observing the child. And then if we observe fluid overload, we notice that the eyelids become puffy. This simply means that the child has been overloaded with fluids. So to prevent cardiac overload or pulmonary edema, we are going to stop a bit. So we are going to stop and then wait for the puffiness to go, to vanish. So when the child is no longer having fluid overload, we are going to start giving the ORS again. So after 4 hours, we want to assess how the plan has gone. So during assessment is done using the chart to determine the presence of some dehydration and severe dehydration or no dehydration at all. So after 4 hours, we have administered ORS, which is 750 mils, and then we want now to assess if our plan has worked or not. So if we are going to assess using the chart, and then if we observe that the child is still having some dehydration, we are going to repeat plan B. Then if we notice that the child has not improved but has even become worse, it has developed now severe dehydration, we have to now switch on to plan C. If the child is no longer dehydrated, then it means our management has worked. So if there is no dehydration, move to plan A. So which is giving ORS slowly. So now let's move on. If we notice that there is some dehydration is present, then we are going to repeat plan B. And we can give some juice to the child. So if severe dehydration, then treat by plan C du gem. So if infection is present, we are going to give treatment. We are going to treat the infection with antibiotics. So antibiotics which can be given, benzyl penicillin can be given, amoxicillin can be given, cefotriaxone can be given, cyprobid and flagyl. Those are the antibiotics which can be given. Also, antibiotics can be given according to the results for the stool for microscopic culture and sensitivity. So if we take the stool for examination and for culture and microscopy, and then it comes back according to the antibiotics which are responding to these bacteria, we're going to administer those antibiotics. So always remember that. So we have assessed our child, and then we've noticed that this child has developed now severe dehydration. So plan B has not worked. We are going to move on to plan C. Now, plan C is an emergency. It means the child has got severe dehydration. They have lost a lot of body fluids and electrolytes, and so it required administration of intravenous fluids. So, the objective is to improve child's hydration status. So, if the child is able to drink, also give ORS by mouth at the time the IV fluids are running. So remember that severe dehydration is an emergency and an IV has to be put in order to administer intravenous fluids. So the intravenous fluids, the fluids of choice are lingers lactate, normal saline, or half strength Diarrhoea. Now, these have to be given at 100 ml per kg body weight, and they have to be given in 6 hours. Now, this 6 hours is divided into 2. So first, the 30 ml per kg body weight will be given in the first hour. Then the remaining 70 ml per kg body weight is going to be given in the remaining 5 hours. So in case this child is in shock, the veins have collapsed, we are unable to cannulate the child, we are going to insert a nasogastric tube. So a nasogastric tube may be used in cases where intravenous infusion is not possible, not both, but not possible. So we are going to insert a nasogastric tube and we will start giving the child ORS through the NGT. So if it's ORS, we are going to give 20 ml per kg body weight in 1 hour for 6 hours. In 1 hour, then the total should be, so if it's ORS, we are going to give 20 ml per kg body weight in 6 hours. Then the total should be 120 ml per kg body weight. So the total should be in 6 hours, this child should receive 120 ml per kg body weight. Then reassess the child every 1 to 2 hours. And if hydration status is not improving in 3 hours, then give intravenous infusion more quickly. So we are giving ORS through NGT. Then after, so the total should be 120 ml per kg body weight. Then we reassess the child. So as we are giving either intravenously or nasogastric, through the nasogastric, we are observing the child. So we are observing the child in every 1 to 2 hours. And if the hydration status is not improving, if it's an IV, we have to run it more quickly, more fast, so that we prevent dehydration. So this is what we can see. This child has got intravenous fluids which are running. So then we reassess the child after 6 hours and then classify the dehydration. So intravenously, we've administered the fluids. We gave 30 ml per kg body weight in the first 1 hour. Then in the remaining 5 hours, we administered 70 ml per kg body weight. After 6 hours, we reassess the child. If the child is still severely dehydrated, we are going to repeat plan C. If some dehydration is present, then we are going to switch back to plan B using ORS. If no dehydration, then we move to plan A. So that is the medical management of a patient with some dehydration or severe dehydration. So remember that severe dehydration is an emergency and it requires immediate care. So now let's move on to specific nursing care that is going to be given to this child or the patient. So we are just going to look at the specific things. So the aim of our nursing care is to eliminate dehydration within 6 hours. So we also want to restore fluid and electrolyte balance. Third is that we want to control the diarrhea, and then we want to treat the infection if present. So the first, we want to correct dehydration. Second, we want to restore a normal fluid and electrolyte balance. Then fourth, we want to control the diarrhea. Fourth, we want to treat the infection. So those are the aims. So when it comes to admission and isolation, which is under the environment, so this child will be nursed in isolation. So nurse the patient in isolation using enteric or barrier nursing. This is going to be achieved through use of gowns and gloves by members of staff, then a basin of water by the door for hand washing after attending to these patients or the room to prevent the spread of infection. Then visitors are going to be restricted to prevent the spread of infection. So this child is being nursed in isolation so that the infection is prevented from spreading. So disinfection of utensils and linen by soaking in Jik 1 into 6 packs is going to be done. Then stool disinfection to prevent cross-infection should be done. Then the room should be well ventilated but warm enough to prevent hypothermia, which can come about due to the loss of body fluids. So the patient will also be nursed in a well-ventilated room, for dehydrated cells do not take up oxygen effectively. Remember that these cells are losing electrolytes and fluids, meaning even their function, their physiology or function is going to be altered. So the room has to be well ventilated. So when it comes to observations, we want to make sure that hourly assessment of food dehydration on general condition of the child to give appropriate treatment. So we'll be observing this child hourly. So we want to assess if our management, our plan is working or not. Then we observe and record stool for color, consistency, frequency, odor, as this may even guide on the type of infection. So we'll also be observing the stool for color, frequency, odor, so that we also, this will also guide us on the type of infection. Remember that we can also have dysentery where we have blood being in stool. So in case this child is having diarrhea and then we notice that there's blood in the stools, which can only be done through observing the stool, we are able to tell that this child has got dysentery. So by observing the stool for color, consistency, and frequency, it can help us, it can guide us on the type of infection that this child is having. So we also observe the flow rates of intravenous fluids according to the plan. So if it's plan C, we know that these fluids that we are administering should run if it's in the first hour or the remaining 5 hours. We want to make sure that we also calculate the drop factor so that we know how much fluids are going to be administered. So we are also going to be observing how the fluids are running. by calculating the drop factor and how many drops should do run per minute. Then if the child is on nasogastric tube for feeding, give according to the amount that has been calculated, and observe for abdominal distension. Remember that we are putting this ORS direct into the stomach, so we want to observe for any abdominal distension. Then we also observe the behavior of the child so as to detect lethargy or maybe restlessness or drowsiness, which are determinants of the level of dehydration. So even as we are administering these fluids, we also want to observe the behavior of the child. Is the child becoming are they still lethargic? If they were in shock, are they still in shock, or they are coming out of shock? So we should be able to observe the behavior of the child, which can also tell us how the response of the management is going. Then also be on a lookout for fluid overload, which will be evidenced by puffy eyes. So when we are giving fluids and we notice that this child has developed puffy eyelids have become puffy, it will show that there is fluid overload, and then we have to stop the fluids to prevent pulmonary edema. So also, if it occurs, we are going to stop. If it's ORS or if it's intravenous fluids, we are going to stop a bit because of the fluid overload. Then under observation, we have to make sure that we record a strict input and output on the fluid balance chart. This has to be done properly in order to monitor the effectiveness of the treatment. So the fluid balance chart has to be recorded accordingly. So the fluid balance chart should be able to show the type of fluids which are being administered, the amount of fluids to be administered, and in how many hours. So the fluid balance chart should be filled in properly. And has the child vomited? Has the child how many times has the child had diarrhea? So this should be recorded properly on the fluid balance chart. So make sure that we do that. So we are going to be recording the intake and output on the fluid balance chart. Also, if we notice, we've already talked about this point. In case we notice fluid overload, we are going to stop the fluids and give the patient some time for the body to absorb the fluids. Then we can give plain fluids and water if that happens. So we have to make sure that we regulate, we monitor how fast or how slow the intravenous fluids should run by calculating the drop factor. So this is what we can see. This is regulating the amount of fluids to be given. So when it comes to psychological care, know that when the child is sick, we have to make sure that we explain the condition to the parents in order to gain their cooperation. So we have to explain. We are going to explain the disease process for them to understand. Then we should explain the treatment and the purpose for controlling dehydration so that they cooperate. So if the child is on plan B, if they are taking ORS, explain to the mother the importance of giving ORS, the importance of controlling dehydration so that they cooperate. If they don't know, if they don't understand what you are doing, it will be difficult for them to cooperate. So it is important that the parents understand why you are telling them to be giving ORS and to continue to breastfeed. Because if they do not understand, it will be difficult for them to cooperate. So because we want them to cooperate and to understand what is going on, we need to explain to them. Then explain the purpose of isolation and barrier nursing measures to win cooperation and minimize anxiety. So when it comes to diarrhea, these children or patients are isolated, and uh, because they are hospitalized, their family members are anxious. They want to be visiting their children, their relatives. But we have to explain to them to say they need to be isolated to prevent the spread of infection. So this may be a little bit difficult because the relatives always want to visit their loved ones who are in the hospital. But we have to explain to them that they cannot be allowed to enter into the room where the child or the patient is being nursed from, because we want to prevent the spread of the disease. So then we have to involve the parents, the mothers, the fathers in the care in order to ensure that the child takes treatment. Because if we remove the parents and nurse the child alone, it will be difficult for the child, even for the treatment to work well. But so for those reasons, we have to involve the parents in the management of the child. So when it comes to hydration and nutrition, remember that we are administering fluids as prescribed by the doctor according to the plan. So if it's plan B, we are giving ORS. If it's plan C, we are giving plan C. So we ensure that the fluid is according to the doctor's orders. If it's in the first 1 hour, and the second one if it's in the last 5 hours. So we're also giving ORS. If the child is able to drink, we are giving ORS, and we are recording on the fluid balance chart. So we also give nutritious foodstuffs to maintain the nutritional status. We don't want the child to become malnourished on top of having diarrhea and dehydration. So we are going to be giving nutritious foods to this child. Then with all animal foodstuffs, unless sour milk. So sour milk can be given to this child to prevent further diarrhea. So we are going to assess the level of hydration status after an hour. If the child is still severely dehydrated, we are going to increase the flow rate of the intravenous fluids. Then we are going to assess the child after 6 hours, and then appropriate plan should be put in place. So when it comes to rest and exercises, so in an acute phase, when the child has just come, they are lethargic, they are dehydrated, they are in shock, they cannot do exercises. So the child will be at rest. So when the child is severely dehydrated, the child is nursed in the bed because of weakness and poor general condition. So the exercises are avoided in the first 6 hours because the child is too weak. After the acute phase, the child can move around the ward. Then perineum care and hygiene. So remember that the child is passing stools very frequently. Frequent cleaning of perineal area and buttocks will be done with application of barrier cream to prevent irritation of the stool. Then, so the mothers should be taught and encouraged to be cleaning the perineum and the buttocks appropriately, and to apply some barrier such as Vaseline can be applied to prevent the irritation from the stool. Then bed is kept clean and dry to prevent bad odor and self-infection. So we want to make sure that if the child has passed the stool, has opened the bowels on the linen, it has to be changed appropriately. Then when it comes to health education, it is important that the parents the mother are taught on the dangers of dehydration so that they can comply with the treatment. Then we also advise the mother to give more fluids than usual to prevent dehydration for strength and psychological balance. So we educate the mother on the importance of giving more fluids in cases of severe dehydration. Then educate on the 3 rules of diarrhea management, such as giving a child more fluids than usual. Then continuing to feed the child even if the child is sick. So if the child is still breastfeeding, the mother should continue breastfeeding. Don't say because the child is receiving IV fluids they cannot be fed. No, the mother should be educated that she should continue to be breastfeeding the child. Then also the mother should be educated on the importance of going to the health center or taking health services whenever the child is not well. So when it comes to elimination, care must be taken in the disposal of stool because it may be infectious. So because these microorganisms can be transmitted through oral fecal, we want to make sure that stool is disinfected. Then disinfection of stool to be done to prevent cross infection. So also we are monitoring the bowel elimination and record the findings. So we should be able to ask the mother how many times as the child has diarrhea or has vomited, and this should be recorded on the chart accordingly. Then also observe for urination, as there may be a reduced urine output due to the renal system involvement. So if the child is severely dehydrated, they may have reduced urine output. So urine should also be monitored. So when it comes to the preventive measures, in case you're in the exam and then they ask what are the preventive measures of diarrhea or acute gastroenteritis, we are going to state as follows: breastfeeding. So we are going to educate the mothers that breastfeeding should start as early as the baby is born in order for them to take in antibodies that are required. Then the child should be breastfed for exclusively for 6 months. This should be done. Then mother to continue to be breastfeeding even when the child is sick. So the mother should continue to breastfeed. So also we also want to educate about personal and family hygiene. We want to make sure that we teach the importance of hand washing after changing the nappy, before feeding the child. Wash child's hands to make sure that the hands are clean. So also improving weaning practices. So we want to make sure that the child, the parents are educated on how to properly introduce solid food to children. So this should be done after 6 months of exclusively breastfeeding. Then it should be gradual. The introduction should be gradual. Then nutritious when weaning of food should be introduced when a child is 6 months, when the intestines are ready to take the food and digest without causing indigestion and diarrhea. So this should be done. Then the child's food should gradually increase, not introducing the child to bulky food at once. It should be a gradual process. So fruits and juice and some other oils can be added to a child being introduced to solid food gradually. So those are some of the points that can be can be mentioned. So hygiene. Then when it comes to the disposal of stools for young children, so mothers should be taught should not leave the stool for younger children around the ward, as this may attract flies that can contaminate the food. So this can occur in the ward. We have to make sure that they are educated on how to dispose their diapers or nappies that they are being used. Also, not leaving stool anyhow. This can also even can happen in their homes, where children are not opening bowels in the toilets, but on the ground, on the environment. So such stool should not be left there because it will attract flies which can be contaminating the food, and you find that children are going to be suffering from diarrhea. So the stool should be thrown in the latrine as soon as possible. So mothers should also be educated on the importance of immunization. They should be immunized against diarrhea diseases such as with the viruses. So also the importance of nutrition should be emphasized. Malnutrition should be avoided because it can cause diarrhea in children. And so this is where our presentation ends. You do well to go through and study through well so that you understand and analyze properly. So thank you for watching and for listening. Remember to subscribe, like, and share. Thank you and have a blessed day.